Good afternoon, everyone, or good morning, depending on where you are joining us today. This is Emma Greenwood moderating today's webinar. I'm the founder of the Pulsatile Tinnitus Foundation and Wooshers.com. We are expecting quite a few people today, so I'll give everyone just a few moments to log in. But we're really happy that you're joining us today for this special iteration of our webinar series. This is our website, the Foundation's website. I have a few very short slides to show you before we jump into our conversation today. I'd like to invite those of you that maybe haven't visited the website to do so. We're very excited about the foundation, which went up and running back in 2019. We're doing a lot of very exciting things, including managing webinars like this and increasing pulsatile tinnitus awareness around the world. And we'd like for everyone to join us, whether you are a patient. I know there are a number of patients joining us today, but also a number of medical professionals as well. So we want to encourage you, whoever you are, to visit our website. And we would like to encourage everyone to donate to the foundation. Of course, this is a free webinar, but if you have the means to donate even $5 or $10 for the webinar today, we'd really appreciate it. We are a 501c3 public charity, and depending on where you live, but hopefully wherever you live, the donation is tax deductible. So we hope that you will consider that to help us and to help you. I'd like to mention just a couple brief things. This is a bit random, but I'm very excited to announce a special partnership that the Pulsatile Tinnitus Foundation has with a company called Sleep Phones. Those of you who have visited the Wooshers.com website over the years know that sleep phones are nothing new to us. Sleep phones are a product that have helped many patients get some sleep from the whooshing heartbeat sound in their ears. What makes their product distinct from other headphones and headbands is that the speakers are flat, as you can see in this slide, just to demonstrate what they look like. They're not really pretty to look at, but the trick is they go inside of the headband and allow you to basically listen to whatever you'd like. Most of the time it's white noise that helps our community the best, but you can listen to Sinatra or jazz or whatever you'd like to help you sleep. And initially, when I joined the community and created Wooshers.com back in 2009, it's funny because a lot of companies would send me products, you know, sound pillows and fans and things like that out of the blue. And most of them, the majority of them, did not really help me very much at all. But Sleep Phones did. And so anyway, the Sleep Phones folks have been very supportive of our community for many years. And they have printed a new version of their Sleep Phones headband with our Pulsatile Tinnitus Foundation logo on it, which looks pretty cool. The cost is the same as if you get a plain colored one on their website. But if you purchase one of these headbands with our logo, a portion of the proceeds will go to our foundation and to our community. You can get the ones with cords that are sort of the old-fashioned, and actually I prefer them, kind where you plug them into a device to play the sound at night. But if you don't want to be, you know, jumbled in wires at night, they do have a wireless version as well. You can also purchase the headband just plain as well. So I just wanted to mention those things. There will be links to the sleep phones on the pulsatiletinnitus.com website as well as on wooshers.com. So now I'd like to present our distinguished panelists for today. I'm not going to go through all of their names because it would take precious time, But these are all doctors who have contributed to our community over the years. The doctors on the left are all on our executive board for the foundation, and have been panelists on our previous webinars. And the doctors on the right are our special guests for today. And I believe Dr. Felton might be running a bit late, so I don't think he's logged in yet. Hopefully he will be able to log in. But Dr. Nelson is from NYU Langone Health, an old, dear, not old, but an old friend to me. Wow. And very, very dear friend to, you should know, everyone in our community. He's done a tremendous amount of work for all of us behind the scenes, and for some of us, not so behind the scenes. So I would like to welcome all of our panelists today. So today's webinar, unlike our others, we've had 4 others, is going to be run a little bit differently. Our past webinars have been really a general Q&A for the doctors on the panel to cover really any questions that patients have about pulsatile tinnitus, from diagnosis to treatments to all, a number of different underlying conditions. We at the foundation discussed that there is a pattern that needed to be addressed that's happening, really has started in the last couple of years with specific diagnoses that are sort of dominating the news in the medical world about pulsatile tinnitus. These are definitely not the only underlying conditions of pulsatile tinnitus. If you're watching today and you just started whooshing, it's very possible you do not have one of these conditions. But in any event, we did want to devote a discussion to specifically transverse sinus stenosis, intracranial hypertension, and idiopathic intracranial hypertension, because there have been a tremendous increase in reports of cases of these conditions in our community, and also discussion and reports about links between them. And so our hope is that this will be an educational webinar for not just patients, but for the medical community. And again, we have a number of doctors and other medical professionals that I know have joined us today, really to discuss the latest in the news, and also for patients to discuss maybe different ways of discussing these conditions with your doctors, and especially if specific treatments have been recommended to you. So with that, I'm going to stop sharing. We have just a few slides, I believe from Dr. Shapiro, who will be helping kind of lay the groundwork for the 3 conditions for transverse sinus stenosis and talking about intracranial hypertension. And this is going to be a very loose discussion. We did take a number of questions, and thank you all for sending them in over the last several weeks. So I will be asking some questions based on what our community members have submitted, but I invite all of our panelists to talk to each other as well, and hopefully we can have a very vibrant couple of hours. So Dr. Shapiro, I'll turn this over to you.
Okay, Emma, thank you so much, and thanks to everybody for joining. I hope you can hear me okay. My name is Dr. Maksim Shapiro. I work at the NYU Langone Health and Bellevue Hospital in New York City. Dr. Nelson, who is, as Emma mentioned, is my mentor, trained me in what I do is neurointervention. And so I just want to briefly, not to take a lot of time, but to give an introduction to, I'm sure many of you know what we're talking about today, but I think we need to just lay some groundwork, as you said. So basically, we're focusing today on the condition of venous sinus stenosis and intracranial hypertension. Probably, as far as we know, the most common cause of pulsatile tinnitus. If we leave away the intracranial hypertension for now, if we just focus on isolated pulsatile tinnitus and venous sinus stenosis. By way of introduction, pulsatile tinnitus is not a disease, it's a symptom, right? It's something that a person hears. And that can have many causes. Venous stenosis is probably the most common, but there are many others. Somebody can have a dural fistula or whatever it is that we're not going to talk about today. And so venous sinus stenosis is one of the many causes of pulsatile tinnitus, which is a pulse synchronous noise. A person hears something that is in sync with their heartbeat. Some people describe it as a whoosh. Some people might describe it as a screech or whatever it is that you have, or somebody told you that they have, but it's pulse synchronous. The key is that it stays with the pulse. If the heart rate goes up because you're excited or exercising, the frequency of the sound also goes up and so forth. And so that's the condition we have. It's essentially the bottom line for most of them is that the ear in most cases is okay. Not all of them, but most of the time the ear is fine. It's just doing what it's supposed to do. It's hearing a sound, and the sound happens to come from the inside. The sound, in the case of venous sinus stenosis, is made by turbulent blood flow, basically blood, venous blood that's squeezing through a narrowing, through a narrowing in a vein that happens to be near the ear. And so because the narrowing happens to be near the ear, and the flow there becomes turbulent and more loud, the ear can sometimes pick it up and people start hearing this sound. One of the hallmarks of that sound that's true for almost everybody who has that is that when a person with this sort of sound pushes on their neck, somewhere in this area, where the jugular vein is, the sound becomes much less on that side. And that essentially has to do with the fact that there's basically the vein, or the sinus, it's called the sinus, but it's really a vein that transmits all this blood, runs from the back of the head around the ear and down to the neck. And so when a person goes like this, they decrease the flow on that side and the sound diminishes. And that's one of the hallmarks. We can get into that later. And so basically that's kind of the basics of venous sinus stenosis. It is related to intracranial hypertension. We'll get into that. People with intracranial hypertension also have venous sinus stenosis, and some people with pulsatile tinnitus have subclinical intracranial hypertension. They don't have other symptoms of intracranial hypertension, but they would have an elevated CSF pressure if they had a spinal tap. And so these things are related in a way that we can kind of unpack maybe a little bit later. The treatments for venous sinus stenosis and related to pulsatile tinnitus, really, we'll get into these questions. How dangerous is it? What do we do about it? Do we venous stents, of course, are an important part of the treatment. When do we use them? How? When is the right time to do it? What are the things you need to be aware of? What are the risks of the procedure? What are the expected benefits? How durable is it? How long does the procedure last if it works? All of these things we want to discuss. As far as materials, I'm going to just share quickly this page just to give you like a very quick resource. This is a page that we had developed at NYU. It's called neurangio.org. It has a ton of anatomical information, other things aside from pulsatile tinnitus, but it has a special section on pulsatile tinnitus. That's right here off of the main page. And you can go through. Here's a kind of a typical picture of somebody with venous sinus stenosis. And there's a lot in there. There's kind of different sounds that people can hear and all kinds of conditions, examples of cases, not just venous sinus stenosis, other causes of pulsatile tinnitus, but there's a lot on venous sinus stenosis. So you could neurangio.org if you, if you'd like to avail yourself of that, you could take a look at it. Now, there's a lot of exciting things that are, I think, happening in our field. Something that we wanted to touch on about, and maybe we could talk maybe later about this in more detail, if there's interest, is development of dedicated venous sinus stents. So several years ago, several companies and groups have started to develop devices, stents, dedicated to treatment of either basically stents to be implanted in the vein for intracranial hypertension or pulsatile tinnitus. None of them have reached FDA approval yet for the United States group in terms of, and so right now we're using other stents, repurposed stents that were made for use in other parts of the body, carotid stents mostly. And we have a long history of doing that. But there will be, at some point, dedicated devices arriving. And I think we could talk about, whether, we anticipate them making the procedure safer or more efficacious is not clear. They're definitely made to be more friendly in terms of deployment. So if you're a physician using one of those, they're kind of designed to work, be a little bit optimized for the veins. But in terms of how will they work better than the ones we have now? Will they be safer? I think these questions remain to be answered. So with that, I think we can probably go ahead with the rest.
Okay, great. Could you or could one of the other panelists maybe take a step back and discuss stenting generally? Like what is the goal with stenting as it pertains to pulsatile tinnitus? Is it to fix just the whooshing, so to prevent the patient from hearing the heartbeat sound, or is there a more clinical, solution being addressed there?
Yeah. So for the patient with isolated pulsatile tinnitus that does not have, like, say, papilledema, which is one of these things that people have that does not have intracranial hypertension, however that's diagnosed. For the person with isolated pulsatile tinnitus, I think in my practice, the goal of treatment is to get rid of the pulsatile tinnitus. And so that's very much a symptom, it's like, and as we can discuss about, like, the tremendous psychological impact of that some people have, depending on various situations. Some people can be profoundly affected by this to the point of, like, contemplating suicide, for example, and they can't work, they can't sleep. And so that's, certainly like a tremendous burden in itself. But in terms of whether a venous sinus stenosis with isolated pulsatile tinnitus is a risk, would that patient be at risk for stroke? Or would they be at risk for other conditions, or like a clot forming in the sinus? So those risks, in my experience, are extremely low. And so the goal is really directed at getting rid of the sound. And so I think people that sign up for this stenting, and that's what we discuss about in our practice, need to be aware that this is not about stroke prevention. This is about your sound. And that's the goal of stenting. There have been attempts to kind of get by with angioplasty, which is basically this balloon that's kind of inflated to try to open up the vein. And the purpose of the stent is to open this stenosis. The stent is a metal tube that opens up and, try to get, basically helps get rid of that stenosis. There have been people trying to do balloon angioplasty, which is something that's tempered, that doesn't leave anything behind. So a stent is not left behind. It's just an angioplasty. It might work in the minority of cases. In our experience, it hasn't been that great. So the vast majority of people that do this end up putting a stent in.
And a stent.
Yeah, I think if I could break in just to clarify that, essentially what's being addressed here, and the reason one has a pulsatile tinnitus, is turbulent blood flow. And turbulent blood flow can be either related to a narrowing in the vein that is coursing behind the temporal bone that houses the apparatus of the middle and inner ear. And so that turbulence is basically heard. It vibrates the apparatus and ultimately causes the pulsatile tinnitus. That can be on the basis of a narrowing. It could also be on the basis of, like, a diverticulum, sort of a pouch that grows off of the normal vein. And the stents are used not just to open up a narrowing and therefore change the blood flow that passes through that segment of the vein, and reduce the turbulence, but also if turbulence is due to vortical flow in a diverticulum or some sort of abnormal pouch, venous pouch, it's used to sort of reconstruct a tubular structure, a tubular venous structure, and eliminate the pouch. So there are different applications of stents. Maybe if Max could show us what a stent looks like, you might find a picture of one so that people have an understanding of it. But essentially, it's like a metal scaffold. There are two sorts. You can sort of divide them up in sort of metals that have to be opened up, expanded with a balloon, or metals that are self-expanding. arranged woven stents. And so typically what we use now are self-expanding stents. They have to be sized appropriately. And the essential intent is to change the caliber of flow going past that venous structure to eliminate the turbulent flow, either arising from a stenosis or an ectasia or diverticulum.
And is a stent permanent?
Yes. People are working on biodegradable devices, but that probably is going to be quite a ways off.
And for
so
the
right now they're metallic.
Okay. And for the medical reports, I guess looking at cases as once a patient has a stent procedure, and I guess hopefully in at least some of those cases, the patient is followed over time so that there can be some sort of analysis of the success of the stent, how long does it last, or does it last? Is there a ballpark indication of how far back that analysis is at this time?
Well, I'll let Max kind of address that. We started placing stents intracranially for pulsatile tinnitus and intracranial hypertension, maybe going back about 10 years. There was a lot of interest in this, ironically, to treat MS, and so that's a cautionary tale, going back about 15 years. But in, I think, many practices, the use in pulsatile tinnitus really kind of extends back about 10 years. And as everything in medicine, it really comes down to proper patient selection. And so as that has improved, as our ability to kind of understand the conditions improved, the application of the tool was more appropriate. But I think in the early days, where this was more broadly applied to just people complaining of pulsatile tinnitus without understanding the etiologies of their conditions, and as you know, there are many, many, many types of reasons to have pulsatile tinnitus. I think probably a lot of the failures were related to inappropriate patient selection.
Okay. I do want to talk about intracranial hypertension because we are going to eventually talk about the link between transverse sinus stenosis and intracranial hypertension. But one of the questions that we had from our community was, are there any risks in not getting a stent if you have a confirmed transverse sinus stenosis diagnosis and you choose not to get a stent? Is there at this time any risk or concern from any of the doctors about that?
Well, having an isolated stenosis, the implications of that depend on a variety of things. Initially and fundamentally on the sort of venous collateral circulation that one has. Some people are born with a congenital absence or a hypoplasia of a sinus, and they live their entire life that way. So having a stenosis is not intrinsically dangerous. It kind of depends on what the contralateral side looks up, how that's connected to the rest of the cerebral venous apparatus. And so it's a complex question, and a lot of it has to do with one's fundamental anatomy and physiology.
If I may add, Emma, if the patient has IIH syndrome, idiopathic intracranial hypertension, we need to make sure that there is no papilledema, because that's a major risk for the patient to lose vision. So provided that there's no papilledema, I fully agree that there's no other major risk. Of course, the patient, can go on the proper treatment for the IIH, which is acetazolamide, basically, and weight loss.
Okay.
Yeah, I want to unpack that a little bit more. So I think for the people that not in medical community, basically sinus stenosis can be seen. So the basic overview is this, that sinus stenosis, venous sinus stenosis, can be encountered either in setting of intracranial hypertension or in isolated quote unquote pulsatile tinnitus. So some people with pulsatile tinnitus do not have intracranial hypertension, and some people do. And so it is important, basically, as far as practice is concerned, say, so if you have pulsatile tinnitus and if you have been diagnosed with venous sinus stenosis, it is important that you have an evaluation by either a neuro-ophthalmologist or an ophthalmologist or an optometrist, somebody who basically knows how to look in the back of the eye and to look for this thing called papilledema that Dr. Sismanis was talking about, which is a swelling of the optic nerve, the back of the eye where the nerve is, and to be evaluated as to whether or not you may have that. If you don't have that, then in that case, if there's no intracranial hypertension, then I think isolated pulsatile tinnitus with sinus stenosis is, other than the sound, is fairly benign. And so must you get the stent right now? For most people, the answer is going to be no. And in our practice, I follow a lot of people, probably the majority of people that come to me with pulsatile tinnitus. A lot of them are just, they don't have a diagnosis. So they're just looking for an answer. Why do I have this, right? And so once you can give them an answer, once there's a diagnosis, if the diagnosis is venous sinus stenosis and the dangerous things are ruled out, we have a conversation. You have this condition. In our experience, it hasn't led to stroke or bleeding or any of these horrible things. If the sound is tolerable, we can talk about all these things you can do to, sleep phones and so forth, noisemakers, mitigations of the sound. If the sound is intolerable, stent is an excellent way to fix that.
And can you have transverse sinus stenosis for years and then later develop intracranial hypertension or idiopathic intracranial hypertension? This is another question from our community.
The problem is, yes. So the problem is that we don't know how long, at any time when somebody is diagnosed with venous sinus stenosis, for most people, there is no prior imaging studies. So we don't know how long they have had that. So have they had it? Most of the time, sometimes when there's a diverticulum or something else, we can infer that they've had this for years. And probably most people that have transverse sinus stenosis have had it for years and years before they develop pulsatile tinnitus. But that's just kind of an opinion. How long will it eventually develop into hypertension? There's also this question of like, what's chicken, what's egg? Does the intracranial hypertension cause the stenosis, or does the stenosis cause intracranial hypertension? These are more like details, medical details, but they are important in terms of our treatments. Probably the majority of people, including myself, believe that the intracranial hypertension is the primary thing and the stenosis is a consequence of that, and not the primary cause, but there are others who feel otherwise. And it just shows, again, like, it's nice when the doctors, if you think doctors know everything, of course we don't. And any doctor should be humble enough to say that there's probably more that we don't know than we do. And especially in this, because this is it's still new. So we still don't understand. Personally, I don't believe we understand what causes intracranial hypertension in the vast majority of people. There's tons of theories, but I don't believe most of them personally. So I don't know. But I know that venous sinus stenosis for PT, I think, is a success story. We discussed earlier how with intracranial hypertension, stenting can be effective initially, but many patients will recur in their symptoms of intracranial hypertension, apart from PT, pulsatile tinnitus, vision problems and whatever. We can get into that. But in terms of pulsatile tinnitus, I think stenting has been excellent in the right patient.
Okay. Dr. Sismanis, you have studied intracranial hypertension and idiopathic intracranial hypertension for, I would venture to say, most of your career.
Close to half a century.
So I would like to give you an opportunity to discuss those conditions in particular, and also I think everyone would be interested to hear in how we've, come along in all these years with diagnosis and treatment.
Well, I first came across a case of intracranial hypertension and pulsatile tinnitus back in 1981. At that time, the differential diagnosis to tell which is the cause, the etiology of pulsatile tinnitus was very limited. Maybe it would include 4 or 5, 6 at most, I would say, different entities. And then over the years, I kept seeing a number of females, most of them, almost all of them. I think all these years I've seen 2 patients with intracranial hypertension and pulsatile tinnitus, that they had pulsatile tinnitus. Now, the common denominator in all these patients was obesity. And in my opinion, the increase of cases that we see of PT parallels that of obesity. At the time when I first described the relationship between intracranial hypertension and pulsatile tinnitus, the prevalence of obesity was about 15% of the population. Nowadays, it's more than 40%. So the other issue with these patients was that once they lose weight, the loudness of the pulsatile tinnitus went down. And I had the privilege of working with one of the pioneers of bariatric surgery that reduces the size of the stomach and results in weight loss. And we had seen with this procedure excellent results as far as pulsatile tinnitus. Now, mind you, pulsatile tinnitus in these patients with intracranial hypertension, perhaps it's the least of their problems. They have a number of other problems. They are pre-diabetics or diabetics. They have hypertension. Many have obstructive sleep apnea. So I think as a physician, you should address all these other issues. But there was no question when they lost weight, the pulsatile tinnitus went down. Specifically, we looked at 16 patients with IIH syndrome and bariatric surgery. And in 13 of them, the pulsatile tinnitus had completely subsided after losing weight. So there's no question that there is some definite relationship between intracranial hypertension and weight. Now we are in the age of the semaglutide and LGBT1 medications, and that will be interesting to see what effect these medications will have in reducing weight and reducing pulsatile tinnitus.
Okay, could you tell us anatomically what intracranial hypertension is, just for those that may not know?
Well, it's an increase of the pressure of the fluid that bathes the brain, and there is no clear reason why this happens. Now, as I mentioned before, the majority of these patients are female, so probably some hormonal dysregulation plays a role, but also weight plays a role as well. What we believe is that when you're obese, you have increased pressure inside your abdomen, and that results in increased pressure inside your chest and inside the blood, the venous blood, inside your head. So perhaps there is some decreased absorption of the fluid that bathes your brain, the cerebrospinal fluid, and that results in intracranial hypertension. Now, recent studies have shown that people with intracranial hypertension have increased CSF, which is not in the ventricles of the brain, but rather in the subarachnoid space. Number two, these patients, again on MRI studies, they have increase of the intracellular fluid. So the swelling, let's say, of the brain is not because the brain cells are swollen, but rather the fluid that is between the cells is increased. That's why sometimes I think we sometimes see reduced size of the ventricles of the brain. And probably I agree with Dr. Shapiro. Most likely, I think, at least in my biased opinion, that this is the reason why we see stenosis of the dural sinuses, including the transverse sinus, which is very often, about 90% of patients with intracranial hypertension, they have narrowing of the transverse sinuses, very common.
So with regard to the weight issue, we, as I know you know, we have a very large community now of pulsatile tinnitus patients, many of whom are told of the possibility that if they are overweight or considered obese, that losing weight will either make the whooshing diminish, as you said, or even go away. What about the cases where the patient does lose weight, significant weight, and there's no change? Or what about the male patient who comes into an office, a doctor's office, and presents with symptoms of intracranial hypertension, or even an overweight male? Where do those cases kind of fit into the literature and the studies of intracranial hypertension?
Now, are these patients with intracranial hypertension, IIH syndrome?
Yes, I'm talking specifically about, well, patients that have at least been diagnosed because of
And they have lost weight and they still
yes,
have pulsatile tinnitus, right?
yes.
We know that one of the findings, as I mentioned, of intracranial hypertension is narrowing stenosis of the transverse sinuses, which we know now that even when they lose weight, when the weight goes down significantly, they remain stenosed. So like Dr. Shapiro previously mentioned, this is probably the ideal case to put a stent.
Okay.
Now, one more thing I want to mention. We have found out that in patients with pulsatile tinnitus, and I think Dr. Eisenman will agree too, that a number of them, they have more than one diagnosis. As a matter of fact, 30% of our patients, they have more than one diagnosis. One common second diagnosis in IIH patients, especially females, is anemia. Anemia is a potentiating factor of the pulsatile tinnitus because it creates a hyperdynamic blood circulation. In other words, your blood in your arteries moves faster. And that's another factor that we have to look. So almost in all patients, new patients that I see with pulsatile tinnitus, especially the ones suspicious for IIH, if they haven't had a CBC, a blood count in the past 1 year, I would get one. Another factor is hearing loss, conductive hearing loss. If you have a patient with a perforation of the drum that has a conductive hearing loss, that's another potentiating factor, for pulsatile tinnitus. And so we have to keep that in mind.
Okay. We have a question from a patient who was diagnosed with intracranial hypertension who received a stent and says that stents reduced my IH symptoms, but I still get some head pressure when my heart rate is elevated. Is there anything that could be done to improve that? And is there any danger to the head pressure?
Well, the patient has been followed up by a neurologist. Does he have papilledema? That's something that I would make sure. Has the patient lost weight? Has the intracranial pressure normalized? I think it needs to be more specifically addressed. Why? Is it a headache, what you described, or she is a female patient? Patient?
This is a female patient, yes.
Yeah, and has
IIH,
right, intracranial hypertension syndrome.
Yeah, I think what they're kind of alluding to is essentially what you were saying with the anemia. So in an exercise situation, the cardiac output is elevated, the heart is beating stronger and faster, and so it's a hyperdynamic. So you may be asymptomatic at your normal resting heart rate. But under exercise conditions where that becomes augmented, then the flow through your brain and everything is increased. And so, they may find that they suffer less at a certain lower hemodynamic condition than they do at a hyper. And that's just kind of normal. Now, in terms of like feeling sort of a pressure in the head, if that's not coupled with an actual increase in intracranial pressure, so there can be many things. You can get sort of venous engorgement, and that leads to the perception of like fullness in the head that has nothing to do with whether or not you actually have intracranial hypertension.
Could be migraine as well.
I think I agree with basically with you, everything. The record, the use of stents for intracranial hypertension is relatively new. I think it's done very well in terms of like near-term control of papilledema. If somebody has visual issues like that, I think the stents do well. Some people will recur, so after a while the stent may stop working. But the track record of the stent in terms of headaches or pressure or feeling like that is much more mixed. So some people, will have great response in the eyes, but they continue to have headache or whatever they describe, the pressure or headache, or it'll become a different kind of sensation. So it's much more. So the short answer to the question is to make sure that the actual, as you both mentioned, if the actual pressure of the CSF is less, then the stent is working. What to do about the other symptoms, I think depends.
Migraine is not uncommon in patients with IIA syndrome. It's very common. Now, is it migraine, true migraine, or is it because of the intracranial hypertension? Difficult to tell.
Yeah, very difficult to tell. Like, migraine can be set off by any number of things, right? Foods and other things. Like, could this also be setting off a separate migraine? We don't know that yet.
Yeah, I think where stents, as I mentioned earlier, where stents are applied to rectify turbulent flow in the basal sinuses to address isolated pulsatile tinnitus, it tends to be a very successful operation in selected patients. Where you get into intracranial hypertension and the connection of intracranial hypertension to pulsatile tinnitus as a secondary phenomenon, that's where it gets a little bit difficult. Because I think I'd like to just kind of, for your viewers or your listeners here that maybe aren't like so sophisticated medically, you can think about intracranial hypertension has to do with essentially the circulation of the cerebrospinal fluid. So your brain and your spinal cord are floating in a fluid inside the dural cavity of the brain and spinal cord. The pressure of that fluid is governed by two things. Like, you can just think of it as a faucet turning fluid on. So the fluid is made as an ultrafiltrate, typically in the choroid plexus and where we describe in the ventricles, and it circulates around the brain and spinal cord. And it's resorbed into the veins and then circulates back into the circulation system. So you have a faucet that's turned on that's making the fluid, and you have a drain at some place, if you just want to think about it like that. And the reservoir that's in the sink depends on how efficiently it's being drained and how quickly it's being made. And so if you have, the reason that sometimes stents work is if you have a problem in the venous resorption of the fluid, it's backing up, and because you have a head that can't expand, the pressure goes up. And so just simply speaking, it's about making the fluid and resorbing the fluid. But that involves a complexity of a lot of things, like how is the fluid actually made and what rate does it get made, and hormones affect that, and maybe the weight of the patient affects it in unknown ways. We can't say that's why the weight affects it. We don't know. And so there's a lot of complexity there, and that's why stents fail in addressing issues with intracranial hypertension. You might get lucky, and you might have a person that has intracranial hypertension because they have a venous stenosis. And so the absorption of the fluid is affected, and that's the primary problem. So that can be addressed with a stent successfully. but they may have a stenosis, and that doesn't really, their problem might be on the production side of it. And so you open up the stenosis, that gives them maybe a temporary benefit, but it doesn't address the fundamental problem that's causing their intracranial hypertension. And then, as was kind of mentioned, a secondary effect of intracranial pressure is to actually extrinsically compress the venous structures. So when you do MR on a lot of people with very bad, high intracranial hypertension, you're going to see the sinuses constrained. Now, that can be maybe temporarily addressed with a stent, but the problem may be in the production of the CSF. And so there are a lot of complex things. And I think it's not the use of stents to address intracranial hypertension is just for that reason, not as simple and successful as where it's used to treat isolated pulsatile tinnitus, either because of a diverticulum or a narrowing.
Should a patient who has been diagnosed with one or the other, transverse sinus stenosis or intracranial hypertension, ask their doctor whether they have the other, or whether they have the other should be examined? Or is that already sort of a fundamental practice by doctors that treat either intracranial hypertension or transverse sinus stenosis?
I would say that definitely there's no like established standard of care here. A lot of doctors, as you know, as so many people, you know, on Bushers and on the Facebook group and around the world, find out that there's a lot of doctors that don't know the first thing about this, you know, and that's not an excuse. That's why we're here. That's why we're doing these webinars, to hopefully educate a lot of people what's going on. So no, there is no standard, but I think you should. I think if somebody has intracranial hypertension, then very likely they have venous sinus stenosis. And so, you know, the effort to treat it would be directed at whatever medication or maybe stents if they have that. So maybe they should ask that, but more for people that have pulsatile tinnitus, isolated pulsatile tinnitus, they might want to ask whether they have subclinical intracranial hypertension, that they might have papilledema. A lot of people I see in my practice, I referred because they went for a routine eye check or something else happened to them, and they happen to discover that they have this papilledema, this swelling behind the eye, that's such a, you know, it's a hallmark of intracranial hypertension, but they don't know about it. You know, they can't, their vision is normal to them. And so having papilledema is a problem because that can lead to vision loss. And sometimes the vision loss is not so easy for a person to detect. When people start losing vision, sometimes it's not like it just grows dark in my eyes. Sometimes the vision gets constricted on the side, and it's hard it would be hard for me to actually know that. So it is important to have an eye check. And so that's, I'll say that. If I can maybe just one more thing I wanted to show, because we kind of started talking about this. I wanted to show this picture on the webpage, because we kind of get into this a little bit. Basically, there are two kinds of, broadly speaking, there are two kinds of stenoses in the venous sinuses. One is kind of compression from outside. We call it extrinsic. And one is there's something in the sinus. You should know that unlike stenosis of arteries, so some of you might wonder, like, is there cholesterol in my veins? Like, why are my veins narrowed? It's not cholesterol. It's not like cardiac or, you know, in the brain or carotid arteries. It's different. So it's not cholesterol. And so most people with intracranial hypertension or venous or pulsatile tinnitus have this sort of extrinsic smooth stenosis that's shown in this MRI. Kind of like here is a compression. This is the jet flow, actually, of fluid. Now, somebody like this is a different patient. They actually have something inside their sinuses. These are called arachnoid granulations. These are like kind of normal structures that we all have. Sometimes they're kind of grouped here. Instead of being distributed over a lot of sinuses, they absorb cerebrospinal fluid. So they do what Dr. Nelson was talking about as part of absorption, is through these things. Sometimes they're kind of grouped in people. And so lots of them happen to be in this place, and they cause venous sinus stenosis. So that's called that's in the kind of more like an intrinsic cause. And these are the people actually that we see much more often that don't fit the bill of the classic intracranial hypertension, like an overweight person or something. A man comes in and he's 60 years old and he said, I've had this for 20 years and nobody can tell me why, and so some people have that. And the stent works great for that because it's intrinsic, you open it. But so I think it's important to mention, like, in terms of that. So that's another factor.
Maxim, if I may say a few things about this. Arachnoid granulation, in our experience, was the third most common cause of pulsatile tinnitus. And these patients usually were older patients. And if you go back in the history, when they were younger, they had headaches. So probably these were the patients that at an earlier stage of their lives, they had intracranial hypertension. They don't have it most likely now, but they have the arachnoid granulations. And by the way, there was not long ago an MRI, I think, or anyway, imaging study that showed that younger female patients with intracranial hypertension, they had less arachnoid granulations versus the older patients. So this is something to keep in mind. Very common cause of pulsatile tinnitus.
I think it's important to understand for the listeners that this is an evolving area of medicine, and frankly, there wasn't much attention given to the venous anatomy of the brain for a long time. It wasn't until people started maybe stenting for MS that we began to pay attention to it. And when you think about it, like many times I think, we're just kind of assuming that there's like the typical venous arrangement in the brain. And that's not the case. Everybody's venous system is like a fingerprint. So it gets to be difficult to kind of understand, like, what is the common factor that leads to all of these things. There are people that, were born with, as I mentioned, a hypoplasia or underdevelopment of a sinus system, and they never had tinnitus. There are people with tremendous arachnoid granulations. They never had pulsatile tinnitus or intracranial hypertension. So, does it have to do with the way that the arachnoid granulation ages? Does it become stiffer with age? And then that gives rise to turbulent flow because it's not as compliant. And that's the problem, is that when we try to make gain an insight into what is a common denominator, a common factor that leads to pulsatile tinnitus, we're starting out with, the matrix of a tremendous variability. It's like a fingerprint. Everyone's veins are different.
Yeah, I think a lot of our community members, and certainly I, have expressed the difficulty, at least initially, in finding a diagnosis, is that there isn't a standard protocol for diagnostic tests. And I think maybe this is a good segue into imaging and the efficacy of different tests. I'm curious to hear from each of the doctors, who, by the way, if this isn't already clear, are from varying specialties. If you could each speak to your specialty, and also, if not a standard protocol for a pulsatile tinnitus patient that walks into your office, maybe a combination or favorite tests, or I know all of our users are eager to hear from doctors about how they might be treated when they walk into a doctor's office so that they know what to expect.
I can say something on that if you'd like, Emma. Obviously, in our situation, I mean, the four of us, the physicians who are here, it may be a little different than in other situations, because most of the people we see have come in with lots of imaging already. So what you're going to end up doing with them, in part, depends on what they've already had. But if you take somebody who's a tabula rasa, who's had nothing done for them, so first and foremost, and I will steal Dr. Sismanis' thunder because he has emphasized this for decades, often on deaf ears, but nonetheless, imaging is not the first step. You need to get a very good history from the patient. You need to examine the patient very carefully, including, goes without saying, looking in their ears, but listening for the pulsatile tinnitus, etc. Patient needs to have an audiogram for many, many different reasons, but not least of which, very simply, you need to know what level of hearing they have. Many people will complain of tinnitus, but their hearing loss is so severe that there's not a chance in the world they would be able to hear their blood flow in an ear that has that degree of hearing loss. So you need to know if they have hearing loss and what type of hearing loss they have. All of that aside, which Dr. Sismanis would have told us about regardless, and this goes to an important point that has been danced around a bit up till now, but not said explicitly. So I'll take that. I will take that opportunity. For somebody to have pulsatile tinnitus, there need to be two things going on. It's not that sometimes there's more than one thing. There always have to be two factors for someone to have pulsatile tinnitus. Number one, there has to be a source producing that sound. And number two, that sound has to have access to the ear, to a working ear, to be able to hear it. People who are profoundly deaf do not have, don't hear their blood flow, no matter how much stenosis they have or how much whatever. And for that matter, most, the sound intensity level of most turbulent flow is relatively small, 30 or 40 decibel. And if you have, for example, stenosis in a transverse sinus, but a thick layer of bone separating that sinus from the mastoid air cell system, there's a good chance you won't hear it. It depends on a lot of factors. So in any patient, you have to look at both of those factors. Is there a source of sound? And does that sound have access to a functioning ear? So with that long-winded introduction, I would say that our favored approach for imaging is one that will show us factors that affect both of those. They will show us sources of sound turbulence, and they will show us the bony anatomy of the ear to know, does a sound that's starting in their transverse sinus have access to the mastoid air cell system where it can get to the middle ear and the cochlea? Is there what we call a third mobile window in the inner ear, which will give the inner ear a heightened sensitivity to hearing a sound that it might not otherwise hear? Is there bone overlying the carotid artery? All these things. And so in our hands, the only way of looking at both of those aspects, the source of sound, the source of abnormal sound production, and the access of that sound to the cochlea, which is the organ of hearing of the inner ear, the only way to do that is with a modified CT-based protocol that looks at the blood flow through the transverse sinuses, through the carotid arteries, other adjacent vascular structures, other sinuses and the like, and also looks at the anatomy of the mastoid, middle ear, and inner ear, which will let you look at both of these factors in any one person. You may then want to, based on those findings, do some other imaging study to look at them a little bit better. But if you're talking about screening somebody initially who has not had any imaging, you need to look at both of those factors. And in our opinion, the only way of doing that is with a protocol that gives you both vascular imaging and bony temporal bone images.
There is very, very, very little that I have to add to what Dr. Eisenman just mentioned. Again, the history is very important. And I want to make sure that what the patient describes when she or he comes to the office is true pulsatile tinnitus, because sometimes patients hear other sounds. For example, there is a condition where the muscles in the middle layer contract, and that's what we call myoclonus, but that's not true pulsatile tinnitus. So I want to make sure that it's true synchronous at the same time with the heartbeat. So I will feel the patient's pulse, and at the same time, I will ask the patient to raise her or his finger when he hears the pulsation. And I like to do that in an audio booth where it's very, very, very quiet. And then I want to compress the ipsilateral, the same side with the tinnitus side of the neck, and see if that goes away. If it goes away, that's venous. And venous is actually the possibility of having something serious is very small. You cannot have an arteriovenous fistula, something that may be associated at some time with a stroke if you have a venous type of pulsatile tinnitus. So it's more reassuring to the patient. And I get an audiogram, as Dr. Eisenman mentioned. So basically, I think that's, of course, what needs to be done, including proper imaging studies.
Doctors Shapiro and Nelson.
Yeah, I think that, you know, like you first start out with a good clinical history. And just anecdotally, the only other thing I might add is that usually this turbulent flow is something that's new. There are many people born with congenital vascular malformations that if you put your stethoscope up to the mastoid eminence, you will hear an outrageous bruit, but the patient is completely unaware of it because that was their internal noise since birth. So usually these are something that evolves in post-adolescence where there's been a change. And that's now new and it's now perceived as a person. But the first thing is like the good clinical history, distinguishing between arterial lesions and venous lesions. And then the imaging adds to that. You can have hypervascular tumors like glomuses, you can have like dural fistulae. Those are the things that we're typically interested in because those are dangerous and also can be, be addressed specifically. And then there's the venous assortment of things. And then, of course, to make it more complicated, we have to connect it to intracranial hypertension, which is another issue.
Almost all vascular tumors that cause pulsatile tinnitus, you'll be able to see them when you look in the middle ear. If they're so far away from the middle ear that you can't see them, the patient probably won't be hearing the pulsating from them. They might, but it's almost all of the ones that they hear, you can see. One way we know this with better certainty nowadays is that we will commonly see patients with large glomus tumors, paragangliomas in their jugular foramen, which go up into their middle ear. Taking out that entire tumor is a bit of a risky venture and fraught with complications. But they're so bothered by the pulsatile tinnitus that we'll often just take out the portion in the middle ear, the very tippy top of that iceberg that's in their middle ear. We'll take that out and the pulsatile tinnitus goes away. And then they can get radiation therapy for the part in the jugular foramen, which has a less risk of complication. I'm not giving recommendations right now for treatment of glomus tumors, but in certain situations, that's the way you do it. And we've learned that just by taking the part out of the middle ear, which is a teeny little percentage of the entire tumor, they no longer hear their pulsatile tinnitus. So if someone's going to hear PT from a glomus tumor, you will probably be able to see it.
I do want to let Dr. Shapiro answer the general question about imaging, but Dr. Eisenman, just tagging on to what you just said about glomus tumor, a lot of patients, as we all know, make a first stop to an ENT when they experience whooshing because it's a very logical thing to do when you hear something that is abnormal to go to an ear, nose, throat professional. The problem is, and this is just articulated by members of our community, that overall the experience of a pulsatile tinnitus patient going to an ENT leaves a lot to be desired and leaves a patient leaving a doctor's office without a formal diagnosis. So I understand with the glomus tumor and probably a handful of other conditions, certainly a trip to an ENT might be a successful, checkboxed step toward a diagnosis. But what about a patient that does not get that kind of satisfaction, I guess, after going to an ENT and maybe checking off all of those possible ENT related conditions as a cause of their PT?
should go to the Wishers site and look at the top 10 list.
Good job, Dr. Eisenman. Yeah.
Thank you. I mean, your question is a much broader question. It's not specific to pulsatile tinnitus, of course. It's a general issue with navigating the healthcare system. And it's a challenging question. But fortunately for our community, there is the PTF and Wishers.
It's a challenging diagnosis to make. There's no question about it. And unfortunately, nowadays, spending 5 or 10, 15 minutes with a patient is not enough to make a good clinical evaluation. I want to make sure that I have at least half an hour to evaluate a patient when I first see him or her with pulsatile tinnitus. So probably I will get a second opinion.
Okay.
Yeah, I think all of us, fortunately, I mean, we have the advantage of working at multi-specialty centers, medical centers, and so it's usually not in isolation. Almost all of these places will have like a pulsatile tinnitus clinic, and so that will involve, frankly, half the cases that I see come from our vascular service, where it could be an elderly person with a high-grade stenosis in the carotid, and that's how they started hearing it. They started hearing their boom, and so that it's a it's a multi-specialty thing. I think the important thing is probably to seek medical care where you have multiple specialists that are interacting, and it usually starts with ENT or vascular surgery, but it kind of moves up the food chain, and you get the input of a variety of practitioners.
Dr. Shapiro, I do want to give you an opportunity to talk about your favorite diagnostic test.
Yeah, sure. No, I think that we've touched on so many important things here. Like this question raised so many important topics to discuss. Like clinical history is very important. Having the right doctor, a lot of ENTs, but others are also just may not be aware of what this thing is. And as you talk, we talk about circulating your scans, right? Like, yes, if your doctor doesn't know about it, even if and it's important for patient, I think, as a service to humanity, to educate the doctors about what they might know better than the doctor, herself or himself. But that doctor is, even if they learn about it, they're not going to be the expert at managing it. They just found out about it the other day, So it is difficult, obviously, for people that are not next to a major center or, wherever you're geographically. So it's fortunately, circulating scans, I think, has become easier in many parts of the world. So what scans that should be? Like, what's the favorite scan? I think practically, when a person hears pulsatile tinnitus for the first time, I mean, generally speaking, the two questions that maybe they don't think of it this way, but the questions are like, what is this? And how dangerous is this? It sounds like it could be dangerous. I hear blood flow in my head, So these are the two questions that the imaging needs to answer. Could this make a specific diagnosis, number one? And number two, even if it doesn't provide a diagnosis, is there any sign of danger there? Is there some big fistula or, carotid dissection or whatever it is? So I think those are the questions that the screening study needs to address. Practically speaking, I think what Dr. Eisenman said, what David said is absolutely like a contrast enhanced temporal bone CT or something like this, very sensitive, specific, very good study. Not available in most places. The ordering that kind of thing might be difficult. So I think most people end up having an MRI. Like in practically terms, they end up having an MRI. So what I suggest, if you're not sure, an MRI with contrast is better. But if you're worried about contrast and people have issues, they're not sure they want to get this contrast injection, you can get a non-contrast MRV, an MR venogram that looks at veins without contrast. It's not most places. Technically, it's not the greatest. Like MRV is not. Contrast MRV is much better in terms of visualizing anatomy, but as a screening study, MRV is something to do, and something called an MRA, an MR angiogram, which looks at arteries, not at veins. So we're talking about venous sinus stenosis, but an MRA is not. It's not for that. It's more to make sure that the arteries are okay, because some of the dangerous causes of pulsatile tinnitus, like dural fistulas or glomus, tumors, for example, you can pick them up on MRA occasionally, depends. But a screening study as an MRA to like look at the bad things, I think is a good idea. So that's like as far as what contrast MRI and MRA are kind of the most likely things to show up in our office. As David said, people come already with scans, and then we take it from there.
Okay.
Emma, we do have, it was a protocol that we had developed ourselves at Maryland, which we use. It is not one that it's not that, you know, is as readily available. It's a sort of a hybrid of really 3 different studies. And we could post that protocol up on the website so people could literally print it and just bring it to a physician and say, do you think this is a study they might be able to do or something like that? There will be pushback from that because any radiologist who is interpreting a film has to be comfortable that it's a protocol they won't miss something on or whatever, but it could potentially be helpful. We could put that up on the site.
That'd be great. Any doctors on the panel, and actually any doctors watching that want to share their protocol, you know, I think that would be really fascinating and interesting and would help the community. We did have a question specific to imaging. And the question is, can 4D time resolved imaging sequences like tricks rule out transverse sinus stenosis on an MRA? Or is a dedicated MRV necessary? And I guess this is going a little bit to what you were just saying, Dr. Shapiro.
Yeah, I can answer that. I think it's, so there are 4D basically means, I mean, for people that are not familiar, basically like MRV, MRA, they're kind of static pictures. They don't give you dynamic information of flow. Like a catheter angiogram, which we're not generally recommending for evaluation of PT, we can talk about that, but that gives us flow information. Kind of watching contrast bolus, watching flow in kind of real time. So these 4D sequences are non-invasive ways of looking at flow. There are CT and MR based. So TRIX is an MR based sequence. So like dynamic MR is injecting this MR contrast and watching it flow. Generally speaking, so the issue is, the answer to the question is probably not. And the reason is, number one, because a lot of them are tricks are set up differently among different places that do this. And number two, they're designed to look at arteriovenous shunts, like a dural fistula. They're designed to pick up shunts. You can see, occasionally you can see venous sinus stenosis on them, yes. But the angles and the things and that, they're not designed for that. So sometimes the way that they're made, you can't really see it well. And sometimes not at all, because it cuts off the venous sinus. It's not looking over there. So the answer is not always. There is the CT version, a dynamic CT, where a contrast CT is injected and the same thing is done. That's actually a little better for detecting stenosis. The issue is most places don't do them because the radiation, it's like scanning it's not one-time scan or twice. It's scanning over time, chasing this bolus. The doses can be kind of serious. So a lot of places kind of moved away from that.
Okay. There's another question specific to IIH. If there are no IIH findings on an MRA or MRI and no papilledema on fundoscopy, can one be confident of ruling it out without resorting to the more invasive lumbar puncture? And we didn't really talk about lumbar punctures, but if one of you or several of you could speak to that test.
Emma, although I'm not a neurologist or neuro-ophthalmologist, I think that there are a number of neurologists nowadays that if they have a strong clinical suspicion of IIH syndrome without papilledema, they will treat the patient without a lumbar puncture, which I agree. It involves some complications, side effects, etc. So there is no problem treating this particular patient with weight loss and acetazolamide, which is the cornerstone of treating these patients.
Sometimes, though, just, not to have people running away from recommendations of lumbar puncture. So sometimes a patient will be being evaluated, and okay, they have a headache, a constellation of symptoms, and intracranial hypertension is maybe one of the suspected issues, but they may be getting a lumbar puncture to obtain CSF for analysis, for thinking of other conditions and things like that. So I don't want people to say, okay, I don't need a lumbar puncture. It may be part of the general workup of the patient's condition.
A lumbar puncture sometimes in these individuals is not easy to do, by the way, because of the obesity.
Yeah. And that's another issue too. If one feels uncomfortable about having a bedside lumbar puncture, frankly, like at NYU, we do quite a few of these under fluoroscopic guidance.
Yeah, that's
so
what we do at my institution as well.
I think that it's important that you can have a refined lumbar puncture.
But by the way, only 35% of our patients with pulsatile tinnitus and IIH syndrome, they had papilledema, swelling of the eye grounds, which is in contrast to the literature that has, what, 95%. The reason is that early on, our neuro-ophthalmologists, they would perform a lumbar puncture and measurement of the CSF pressure in people without papilledema. And we have found out that a number of these patients, they do have increased intracranial pressure. So I keep that in mind as well. I bet some of these patients, they go undiagnosed because they don't have papilledema, and the guidelines for establishing diagnosis today is to do a lumbar puncture and have also papilledema.
I want to talk about the cerebral angiogram, another diagnostic test that we haven't really touched on, but I wanted to first ask you, I guess, with what Dr. Sismanis just said, what is, I mean, we've been talking for an hour and a half almost, and you know, I think each of you has mentioned different tests and the possibility that either the wrong test or you know could be prescribed for a patient and the diagnosis could not be detected of venous sinus stenosis and IIH. How these days, sitting right here today, how difficult is it, or is it difficult to diagnose a patient with IIH or with transverse sinus stenosis?
Okay, I'll say something about this because we talked about the, you know, since we're beating up on the doctors on the medical field, you know, and the ENTs not knowing what this is. The flip side of that is if I had a penny for every time a patient with transverse sinus stenosis had their MRI read as normal or MRV read as normal, as I'm sure many people, you know, and the group have as well, like this is a problem. You know, problem is sometimes their exams are misinterpreted. You know, to get on an MRV, if somebody has a contrast MRV or a contrast like a David's the T-bone CT kind of thing with contrast or CTV, yes, they should be able to see it. So again, like what you're saying, circulate your scans. Once the question is raised, do I have a transverse sinus stenosis or not? I should be able to have the test for that. And the test for that should be interpreted, you know, appropriately. So if it's not, if it says normal, maybe worthwhile to show to somebody else and say, hey, you agree or not.
I fully agree, Maksim, with what you just mentioned, because a number of radiologists, I think, the main thing they want to rule out is a thrombosis of the sigmoid of the transverse sinus. So they say no thrombosis present. And then when you look, there is stenosis or arachnoid granulations, which sometimes they won't mention. And it can be a cause of pulsatile tinnitus. So I fully agree with you.
The other thing, so thank you for bringing this up, because sometimes this stenosis is misinterpreted as thrombosis. So that's the flip side of that. And so a patient comes to us and they're, you know, they're ready to put them on anticoagulation medications and treat the so thrombosis of a sinus is, for people that don't know, there's clot that can form in the sinus for various reasons. That can be, that's a very potentially like a very dangerous thing. Very, you know, most people don't have pulsatile tinnitus. They don't present with that, but they're usually sick, and that can be very bad. And so nobody wants to miss that. But so most people with venous sinus stenosis don't have current associated thrombosis. It's like reportable. There's a couple of cases in the literature, but it's extremely rare, extremely rare. So that's another important point. That's more, again, the denominator is circulate your scans.
And so just piggybacking on that, what that really means, right, is not just circulating the reports that the doctor have written up, but the actual pictures, the images.
Exactly.
You need imaging.
Exactly.
You need, and not like a snippet like what you take with your phone at the doctor's office. Sometimes it's good enough, and most of the time you're gonna go to a doctor, you need the whole thing.
Right.
Emma, I tell my patients, when you have your study done, your imaging study, please ask them to give you a CD with the study and bring it to me. I want to see it myself and perhaps get another opinion by another radiologist. This is not uncommon.
Also, I think it's important we talk about this too. You know, MRIs, CTs maybe not less so, but MRIs, you go to places like the people that have like a 15-year-old MRI machine someplace, and somebody else next door, or they have next door in their own practice, they have a brand new machine. The machines are very different, and the quality of imaging is differences in MRI is vast. So if you're getting your insurance is just paying for MRI, so you might have to do some legwork, ask your doctor, ask themselves like, how new is your MRI? You know, 3 Tesla MR, so they come in strength. Like Tesla is a sign of like a measure of magnetic strength of the field. So a 3T or 3 Tesla MRI is generally a pretty good one. So if they have a 3T, maybe that's like one kind of way of knowing how good it is, but find out that you might want to do some background research on that.
Maksim, don't you think that most radiologists nowadays, when you send somebody with pulsatile tinnitus, the main thing they want to rule out is an AVF, an AVN, something arterial?
Dural
Yes,
fistula.
that's common. That's very true.
Yeah,
And also, there's just like not a lot of, I think experience diagnosing venous problems, other than the classic sinus thrombosis. So I think, that it's always behooves you to get multiple opinions, multiple views. You need to have the CD. And yes, the focus classically is on dural fistulas, hypervascular tumors, and stenosis, vessel stenoses, aneurysms. That's what they're primarily looking at. And frankly, that's an improvement from 20 years ago when dural fistulas were almost unknown and misunderstood.
Dr. Nelson, about those conditions you just described or you just relayed, is the cerebral angiogram still considered the gold standard for detecting?
So by the time, the other methodologies have gotten very good, and as Maxim insinuated, like the technology for MR is always improving, and also CT, dynamic CT, so that you can many times arrive at the diagnosis with transaxial imaging. When you come to the angiogram, it's usually kind of at a tertiary stage where you are like, there's a suspicion of a dural fistula or something that has to be diagnosed by angiography. And there's also an intention to treat. And so by the time you get to an angiogram, you really want to go to a center that's equipped to do that. You don't want to just go in for a diagnostic angiogram. You want to go into for a purposed diagnostic angiogram. So they're going to consider, do you have arterial lesions? And if you have, if it's for a venous study, you want them to couple it with pressure measurements and things like that, because what appears to be a stenosis may be functionally not a stenosis. And so it's very complicated. I think the further up the imaging food chain you go, the more important it is to get to a center that like really specializes in this problem. And has, a sort of a broad depth of skill.
And this would be like a university hospital, for example, or?
Well, it could be a private practice hospital, but it needs to be a private practice hospital that's somewhat sophisticated. That has the multi-specialty dimension, that has people that have experience with this condition and that sort of thing.
I'll say something to that, because a lot of people come to, as Dr. Nelson said, they come to an angiogram because they've had this or that study and they still don't know what is the cause of the pulsatile tinnitus. If they've circulated their scans to a bunch of people, if they've been looked at by experts, the yield of an angiogram in uncovering some problem that has escaped detection by good transaxial imaging, that suddenly, oh my God, there's a dural fistula we didn't see or something like this, the yield of that is very low. Just in practice, because transaxial imaging, non-invasive imaging has gotten so good. So in our practice, when we do an angiogram, it's to obtain some kind of information that we don't have on imaging. And it's not so much to detect the problem, it's more interrogation, balloon test occlusions, venous pressure measurements, because venous pressures, just like CSF pressure, so to mention to the group, the reason all these things are more complicated is because blood pressure, you can measure in the office. We cannot measure venous pressure unless we put a needle in the space where that compartment is and measure it. The venous pressure is the same thing. We have to put a catheter in there. There's no non-invasive way of measuring that. And so that's the yield of the angiograms or venograms, is to do that. And I think that's true of a lot of, if you ask other groups, other busy groups that do a lot of venous stenosis, stenting, or venous work, there's a bunch of doctors on this that are connected, and there's other places, many other places that do this. Most of them don't do angiograms for diagnostic purposes. It's more with some sort of intention to treat or something like that.
Is that a change from like 20 years ago? Was
Definitely.
the angiogram?
Definitely, like it used to be that, like the angiogram was very important for diagnosing dural fistulas. Like you might have a suspicion or you may not from the MRs that were done 20 years ago. And so the patient would have a pulsatile tinnitus, they come to an angiogram for a diagnosis. I think even like in the past, that's changed in the past 10 years, but over 10 years ago, a lot of people were coming for diagnostic studies to angiography.
I fully agree. When I first started back in 1981, everybody with the pulsatile tinnitus had to have an angiogram. That was the gold standard, 100%. And most of them, they would come back, of course, normal. And then we would call it idiopathic or venous hum. And the worst thing, some would recommend ligating the internal jugular vein, because when you put pressure here, the tinnitus, the pulsatile tinnitus stopped. So there were well-known otolaryngologists who were recommending ligation of the internal jugular vein as a novel modality of treatment for pulsatile tinnitus. So no question, we have come a long way.
I think that's very important. We've actually seen an increase in reports from patients who have had that recommendation made to them. I guess what can, I have a couple questions to tag along with that, but what can a patient do if their doctor recommends that particular procedure? It's not so easy to find another doctor. The other thing I was going to say was, our community represents pulsatile tinnitus patients everywhere. We have patients from big cities. We have patients from countries and cities and towns you've never heard of who, have a very difficult time finding any doctor, much less a doctor that knows anything about our cases. So how can we help patients get the type of help?
I would never recommend this procedure.
Yeah, I think you have to be very cautious. And I'm not going to say, I think it may occasionally be a rational treatment, but I will say, I learned the lesson of the relationship of venous stenosis to intracranial hypertension from dealing with patients who had iatrogenic intracranial hypertension related to the sacrifice of a jugular vein. And so, you need to be very careful about what is your collateral circulation. Can you tolerate that? There's some people that have one big transverse sinus, and the other one is the whole brain drains through one ipsilateral sinus, and taking that jugular vein can be very problematic. Now,
Is
you
that
can get away with it
reversible?
many times because of the collateral venous circulation, and it could rectify your problem. But you need to be very, very cautious about that.
And the
Yeah.
occlusion is not reversible, right? Once you do
Well,
that.
once you tie it and cut it and sever it, no, it's not.
Okay.
Emma, one thing I would just say to answer the question I think that you were trying to get at, though there's no great answer, is it should never be recommended as a treatment if the formulation of it is, well, we don't know what's causing your pulsatile tinnitus, we're going to try this. If someone specifically sees something going on in the jugular vein, and you know, as we all know, for every rule there are exceptions, and someone might have something very specific going on in their jugular vein that's causing it. There might be some reason why you would, but it should never be undertaken as a treatment as, well, we've looked for everything we could, we don't see a cause for your pulsatile tinnitus, we're going to do this. It should never be done in that circumstance.
I'm aware of cases that because there was underlying intracranial hypertension, it accomplished the exact opposite result. The intracranial pressure increased, the loudness of the pulsatile tinnitus increased. So, strongly condemned.
Yeah, I mean, you know, like you can go back to the history of people that had IJ venous catheters and anesthesia for a variety of operations, and you'll find a host of people that close the sinus, close the vein. They then end up draining through transmastoid emissary veins into the suboccipital veins. That increases the turbulence through the temporal bone. They start to hear a tinnitus, or they get into trouble with intracranial hypertension because of the closed vein. So it's very individualized. I'm not saying it couldn't be a rational therapy for some people, but you need to really understand your particular venous anatomy before you get into those kinds of treatment recommendations.
Yeah, and I think as Dr. Nelson mentioned, as much as like Emma, I think people talk about like occasionally sacrificing the jugular vein. There's a lot more people that end up having their mastoid veins coiled. And if you hear that, like people hear like we have a transmastoid vein, like that gets advertised. So there's a whole, it's very complicated. Like people that do venous work, they know that, for example, the amount of drainage in the jugular vein depends a lot on our head position. Like we do our angiography with people laying down, there's a lot more drainage through the jugular than actually all of us sitting right now. We're draining way less through the jugular and way more through these like condylar, mastoid, all these other veins. So it's very complicated. We don't understand a lot of that, but we know that's true. So sometimes somebody has a big condylar vein and that gets coiled off because, you know, there's a thought that, and sometimes that helps pulsatile tinnitus. That can help. Just like tying off the jugular might help for a little bit because they don't have the flow, but then other things emerge. So in that, like that's on the spectrum, these mastoid veins, these other veins, closing veins, basically the message is be very careful with closing veins because we can't make new ones. It's hard to, the body can adapt a little bit, but we surgically we can make a new artery occasionally. There's a complex surgery where you can bring an artery from outside to inside. We can't really do that for veins. So before we take a vein, we have to like, you know, measure many times and make sure that we're doing the right thing.
Okay. Dr. Shapiro, do you want to talk a little bit about the evolution of stents and any news that might be on the horizon with regard to new things?
Yeah, I could talk a little bit about it. I mean, some of it is like commercial stuff and trials and like startup companies. So it gets into this kind of space. But basically, you know, there's in the United States, you know, there's 2 companies, maybe there's a couple of others around the world that are working on kind of developing dedicated venous stents. Some of them, so one of them was evaluated for intracranial hypertension, and others are trying to do the same or go for like an indication for pulsatile tinnitus. Basically, at some point, we might be in a space where there could be a trial coming. So there could be a trial where if you're suffering from pulsatile tinnitus, you might be told that there is a experimental device that's on trial. It's a venous stent designed for veins that might be offered to you instead of, like, say, the stent that we use right now, the stents that we use now, which are not dedicated to veins. So the idea of creating venous specific stents, I think, is very rational, right? We are using arterial carotid stents mostly for this, and to good success, but they're not designed for this. And I think we can do better. The question really is, will they be, they might be easier to deliver, you know, as a physician, deploying them might be easier or better, but will they be more efficacious? Will they be safer? These are the questions that have to be answered in a trial. So that's why the trials will be, you know, that's the questions they will be answering. I think they remain unanswered. My personal opinion is that the success of the procedure is very much, like we talked about, is about selection. It's the right person. The person with the stenosis, who you go like this, the sound stops. I mean, that's more or less the kind of person we're talking about with pulsatile tinnitus in general. So it is very much about patient selection. The safety, and then the other things will have to be established. But I think in terms of, like, when is this coming, could be in the next year or two, that these kinds of discussions may be presented to our listeners and to the community.
Great.
They in terms of device, so one more thing. So, like, we kind of alluded to this. Although we've been doing venous sinus stenting for pulsatile tinnitus for about 10 years, the use of stents in the sinuses predates that. So that's been around for maybe, I don't know, 15, 20 years. Like, we've used it for other, like, odds and ends, you know, somebody with whatever condition. So we have put stents in the sinuses, and in the arteries, stents have been around for almost like 25, 30 years. So there's a lot of experience in terms of the materials. Like, are the materials okay? Are they causing some issues? I believe the materials are, you know, the established ones are really fine. They're designed to stay inside vessels. But we have, for the new ones, they're generally, they try to make them of the same things that the others are made, but it'll depend on details.
And for the procedure of inserting a stent, unfortunately, we don't have an international panelist to say anything about this, but I'm curious if anyone can speak to other parts of the world, not the US, that are seeing the same cases that you are, and any differences or similarities, or are the doctors talking to one another in the UK and the US? And can you just talk a little bit about that collaboration?
Yeah, no, yes. This is a small world, I think, in terms of these people that do this. Yeah, people are talking to each other. A lot of the trials might be international. And so I think generally the techniques tend to be similar amongst us for this. There's some preferences, this or that stent, this and that, but in general, they're kind of similar. And yes, people like there's recognition. So in terms of society, so in the United States, there's a society called SNIS, Society of Neurointerventional Surgery, of which I'm a member, and we participate in several years ago, a venous kind of, like, they decided to dedicate a venous attention to a venous specific meeting. So there's an annual venous meeting that I'm also part of, just for disclosure. But basically, there's more attention from medical societies to this as well, which is great, right? Because that facilitates, and one of the major things about this in terms of these kinds of efforts is to facilitate communication amongst the different specialties, like ENT, neurotology, neuroophthalmology is a big one that I think we don't have a panelist in neuroophthalmology, but that's a very important, another specialty in this. So all of that needs to be covered, and I think it's moving in the right direction, but it takes time.
We definitely saw an increase in patients getting the diagnostic tests that their doctors recommended because of the diagnostic codes. for pulsatile tinnitus that our organization was a big part of making happen. We do, however, and I don't want to harp on this, but I know there are a lot of people from the UK in particular who are watching today and who are members of our community, who, for better or worse, is part of a healthcare system where pulsatile tinnitus maybe isn't as recognized. I shouldn't say maybe, it's just not, generally speaking, as recognized as it is here. So you walk into a doctor's office, as a patient, you walk into a doctor's office with pulsatile tinnitus, they hear tinnitus, you have ringing in the ears. If you're lucky enough to get a referral to another specialist, you're still waiting months and months and months to get that appointment. But still, unfortunately, all too often, the doctor will hear tinnitus ringing in the ears and say, live with it, and will not give you the, gold slip referral to another specialist. So you're kind of on your own to go private, I guess. Is there anything that we can say to those community members, patients who are right in the smack middle of, trying to get to the bottom of this, and they're hearing all of you say how significant pulsatile tinnitus is, and we know it is as a symptom, but to help them maybe get help, because I know there are a lot of people desperate for any advice in that regard. And it's not an easy answer, so I don't want to put anybody on the spot, and I don't know if we'll solve that today, but any helpful advice, maybe in the age of technology and taking advantage of contacting maybe doctors on this panel or other webinars that have offered, to communicate with those patients and maybe give them some advice about colleagues that you all have in other areas of the world who might be willing to review their scans remotely?
I would recommend to start seeing, as it was mentioned before, an ear specialist, ear, nose, and throat specialist, and go from there. I know it's not easy if you have a socialized type of medicine system, but I really don't know what else to recommend. Now, consulting our website as well can give a lot of guidelines or guidance to PD patients.
I agree with Dr. Sismanis. Obviously, it's a complex problem. It's really about navigating a healthcare system that, is, it's more about that than the medicine. So I think, we are a community, we are a foundation, we have the tips for doctors. I think there's more literature on that. You can maybe contacting other members of the community, asking them how they navigated the system might help. It's obviously it's very frustrating, particularly in some countries, as you mentioned. But it is a work in progress. I think, so specific to, like, say, England, some places you kind of know that there was maybe 1 or 2 people that were doing this. Now I think more and more there's a little bit of an effect, like the ball starts rolling. There are more people around, so that could, I think that's another plus. There are options.
And I didn't mean to single out the UK before I get emails from, members of the government. But there are, all kidding aside, there are people watching from parts of the world where, there are not medical professionals that know anything about pulsatile tinnitus. So as Dr. Sismanis mentioned, on our foundation website, we have a couple of documents written by some of our doctors on the board for the foundation. One in particular written for doctors that patients are encouraged to keep in their back pocket when they go to the doctor, if they're not sure whether that professional will know a lot about pulsatile tinnitus. So that's really been helpful for patients in our community to take that with them. And I think we have another document also written by the doctors on the board with general kind of background information about pulsatile tinnitus for the patient's understanding. I did receive a few questions from parents, just going back to transverse sinus stenosis and IIH. Parents, in particular, parents whose kids have described whooshing, have described the pulsatile tinnitus. And I wonder, we don't have a whole lot of time left, but I wonder if we could talk at least a little bit for those, parents who, I know all of us that are parents can, appreciate the sort of horror of having your child describe that they hear a heartbeat sound in their head and what that might implicate. Have any of you had experience with treating children in particular with transverse sinus stenosis and IIH? And is there anything that you can speak to about how children are treated and diagnosed, I guess, that's different from the same for an adult?
I don't think it will be any different, Emma. I think they need to see an ear, nose, and throat to do a thorough examination, look at the ears, make sure there's no middle ear pathology like a vascular tumor or whatever. But IIH, it does exist in children as well because of the obesity issue that, of course, affects children as well. So I don't think the workup is very different than any adult, as far as I can tell.
I think the likely diagnoses that you'll find probably differ in children than in adults. I have not seen a lot of kids with pulsatile tinnitus, though we have seen some. Out of the 100+ people with sigmoid sinus diverticulum or dehiscence that we've operated on, there were 2 kids, both and less than 14 years old, let's say, quite, I don't know, interestingly or intriguingly, or they both did beautifully. Both of them, when I saw them back many years later, incidentally, for other things, when they were say late teens, they both were obese at the time. The time that they had the problem, they were not, which obviously that's a very small number to draw any conclusions from, but suggests that our whole thinking about the relationship between these problems and obesity may be backwards. But we don't see it a lot in kids.
I can add that yes, we do treat children. I think in terms of pulsatile tinnitus as a symptom, it's very important if a child, especially if one can hear the sound, but even if they don't, if you're convinced that they're described, there's a chance that there's pulsatile tinnitus. I think thinking about an MRA is important because MRA picks up dangerous things. As David mentioned, the differential diagnosis, the prevalence of different conditions is different in our experience. More children will have, some kind of fistula or some, not such a good thing in their head. And that has to be just managed because it's a risk for, stroke and bleeding and all kinds of seizures, bad things. And so that will be addressed because of what that is. For the children or teenagers or something like this, usually with intracranial hypertension, it's as we mentioned, I think the management is similar, medical management, looking for underlying causes. We started off talking about secondary, like IIH versus, right? Like some children will have, and adults too, have an underlying condition. So they're not idiopathic. The idiopathic means we don't know what's going on, why they have it. They might have something like whatever you mentioned, a growth hormone secreting adenoma, for example, that causes this thing to them to have intracranial hypertension. So that needs to be investigated. Can children be stented? Very rarely, like teenagers, yes. Can it be done? Yes. Same caveats as adults, like might not work might recur, this and that. but that's specific to intracranial hypertension. Also, isolated pulsatile the venous sinus stenosis is a little different. Yeah.
So there have been IIH patients who are children who have been stented?
Yes. Yes. And I think there's like these are anecdotal reports. Numbers are very small. We obviously try not, you try to not do that. Medical management and see if how they do with, acetazolamide or something like that. But I think the other thing that we should mention, coming just sort of around the corner, there's, I'm aware of at least 2, possibly 3 efforts, 3 different groups that are trying to launch studies to evaluate shunt versus stent. So that's specific to intracranial hypertension. People used to refractory intracranial hypertension treated with a shunt or whatever other things, but basically like a shunt, ventricular something shunt. Now that the stents are around, the question is which one is better, right? So at least 2 in the United States and 1 abroad. Questions about recruiting multi-center studies, randomized studies, randomized, offering people with, say, vision loss, how would you like to participate in a study? Shunt versus stent. We'll kind of randomly assign you to one of them. If you agree, this is how studies are done. This is what it takes to advance medicine. Is people kind of volunteering for these if they're willing. So that's possibly coming. Something else to,
Unfortunately, shunts have relatively high failure in these patients because of their obesity.
No doubt. No doubt. This is like the issue is that, shunts are not ideal. Stents are also can fail. What to do. I think it'll take a little bit of time to find out like what the GLP-1, like the whole revolution with the agonist, like how does, pharmacologically useful, meaningful weight loss, what that's going to do to that population. So I think there's a lot of things that are coming. Yes, recruitment for such a study, given the numbers, given this, and how to select the patients, it's not going to be easy. Yeah.
Well, we only touched the surface today, I think, on this topic. So we'll have to talk about maybe having a number 2 discussion about IIH and IH and transverse sinus stenosis. Is there anything that any of the panelists wish to say in closing?
I would say for patients with IIH syndrome and obesity, controlling the obesity issue is the most important factor, not only for the pulsatile tinnitus, but also for the other associated comorbidities, which I mentioned before. So by any means, reducing weight, and I'm not saying about going to normal weight, even 5 or 6% reduction of the body weight may result in significant improvement of the intracranial hypertension and, of course, the associated pulsatile tinnitus.
I would say the one thing I would add, Emma, is on this topic is if you had symptoms and concerns and you went to someone and you were told you did not have IIH or papilledema, a year or 2 later, it's worth always keeping in touch and getting yourself checked out again. This is a dynamic situation. It's not an isolated thing. Things evolve over time, hormonal changes, weight changes, other changes that we probably don't understand. And just because at one point you were told you don't have something, if you're having persisting symptoms or new symptoms, you should always get it checked out again.
Particularly in the pediatric patients. It's
Yeah.
important to follow them.
The one thing that we didn't really touch upon, and it's a complicated one, is all this business of extracranial venous stuff, cervical venous, jugular stenosis, all these other things that I think are coming up. And I'm sure a lot of people in the group are interested. Somebody says, I have a C1 stenosis of my jugular vein. What I do about that? Like, how do I deal with it? Do we stent it? Do we operate? Do we do what? Do we do nothing? So I think that's another thing that it's complicated because imagine like what we are talking about now is a lot of things we don't know. There it's much even, a whole other degree of things, but it is important because people are doing things about it, investigating it. Something else that we probably should talk about in the future.
Yeah, I have a whole list of questions that we didn't even get to. 2 hours is not enough time to cover this important topic, but I want to thank each of our panelists for their time today, and we will most certainly have another webinar very soon, and maybe even a continuation of this discussion. So thank you all again to each of our panelists for your time. We invite everyone who has been watching for the last 2 hours. Thank you so much for joining us. Please visit our foundation website at pulsatiletinnitus.com. And we always have whooshers.com. We are still trying to revamp that site because there's so much copy and text there to dig through, but we're working on it. And once again, if you have the means, if you could provide a donation to our foundation, we'd really appreciate it. You can find the donate button on our foundation website. So thank you.
Thank you very much for your good work.
Thank you.
Thank you, Emma, for everything you do.
Thank you very much.